It's time. Shall we
Yeah.
start, Deepak?
Yeah, you can start, I think, Dr. Kaushik.
Santosh?
Yes, sir. Yes, sir. Deepak sir is joining, sir, within a minute.
No, you can start. You start.
Just a second,
So,
sir.
good evening, everybody. On the behalf of Indian Society for Pediatric Neurosurgery, it is my honor and pleasure to restart this virtual classroom. This will be a continuous series of classes held every month, and the whole thing is planned by Dr. Ranjith and Dr. Ari, the two dynamic leaders in our current EC team. And this has been generously sponsored and supported by the DigiNeuro, a channel which has lot of YouTube videos and webinars that were uploaded from during the COVID times. We invite all residents to go to that channel and see that. It will be our effort from the society to carry on these educational activities on a regular basis. And without much wasting time, I will hand over to Mr. Santosh or Mr. Deepak from DigiNeuro for a small introduction, and then I will take it back again. Santosh?
Yeah. Yes, sir. Yes, sir.
Deepak ji,
Yeah.
good evening.
Sir, good evening, sir. So
Good evening.
we are very, very happy and we feel privileged to support this program, of a very unique program started by a pediatric neurosurgery group. So this is, you can start this thing. So DigiNeuro is an attempt, a channel on YouTube started in COVID days to support neurosurgery demonstration and training program. So this is a digital initiative by Health NU. We are always together with you. Health NU is a company in collaboration with New Link Company Limited, Japan. And we are in neuropsychiatry.
Sorry, Tanya Vichikrenna, I have to motivate her to do.
There are more than 90 plus webinars uploaded on this DigiNeuro channel. You can go on YouTube and type DigiNeuro. Speakers from 12 countries, including speakers who are present here. 1,200 plus neurosurgeons have subscriber across the globe. You can also become a subscriber. This is in joint venture with New Link Company in Japan. We are very, very happy to support this program. We are in CNS. This is our team. And these are our products. Amnurite in neuropathic pain, tension type of headache, migraine. Icogaba NT in neuropathic pain. Amnurite P, amitriptyl plus pregabalin combination, and Prerite D, pregabalin plus duloxetine combination. And that's about it. Please carry on with your program. We are very, very happy to carry this. Thank you so much.
Thank you, Mr. Deepak and Mr. Santosh. I now hand over this session to our moderators, Dr. Ranjith and Dr. Ari, who will welcome our faculty and take it forward.
Yes. Good evening. Am I audible?
Yes, you are audible, sir. Yes,
Yeah.
sir, you are audible.
So first, a few housekeeping requests before we start. The host, I request to keep everybody muted other than the speaker so that we don't have disturbance between the talk or
Sure,
between
sir.
the discussion.
I will do that, sir.
Okay, please make sure that everybody is muted and not by mistake it opens up and disturbs the meeting.
Okay, sir.
And on behalf of INDSPN, we are very happy to start this program. Restart, we were having it in last year and there was a small break and we're restarting. Let me give a small breakup as to how this will proceed. And the objective of this program and the way we are structuring is to mainly benefit residents and the young neurosurgeons. And we had two objectives in mind when we started this in this different format. The first is it should not be just monologues or lectures by 4 or 5 faculty and everybody would else listen and probably not have their chance to ask questions or discuss. So we kept it, more time is kept for case discussions so that queries can be raised, doubts can be cleared, differing viewpoints can be discussed. And there will be two talks, one in the beginning and one the end, which will cover a part of the management so that we get an idea regarding guidelines or protocols. So we'll be very happy if this program is useful for young neurosurgeons as well as residents so that they can ask their questions freely. My main request is please leave your reluctance and ask your questions. And to keep the discussion smooth, we'll request them to put their questions in the chat box. And if it is not too crowded, then we can allow them to ask their questions themselves. But as of now, when in case discussions, as well as in speech, we'll take the questions in chat box and the moderators will take the questions. As far as the case discussion is concerned, the flow will be one person from an institute will present the case. I request to keep it about 5 to 10 minutes, 5 to 8 minutes. Then the discussion from another institute would discuss what he would do for that particular patient, what would be his plan, what are the challenges that he anticipates, and what are the problems that he can think of. Then then the panelists, Dr. Diop, in this particular today, Dr. Deopujari and Dr. Dilip Panikar, two of our senior neurosurgeons, would give their expert opinions and comment on the case as well as the options available. Then we'll take the questions from the audience regarding the case as to what they would do or what are the doubts they have. Then we'll ask the initial presenter as to how they manage the particular case and what is out. This will be the plan for both the cases. We plan to spend 1 hour for this case discussion, 15 minutes for the initial talk, and the 15 minutes for the final talk by Dr. Aliasgar Moiyadi. And we sincerely hope that this will be useful for the young neurosurgeons and residents, and we'll keep it as interactive as possible. Thank you. Dr. Ranjith, a few words.
Good evening to everyone, and I would like to welcome Dr. Deopujari, who's joined us, a panelist. Dr. Dilip Panikar has not yet joined, I think, but he'll be joining soon. Dr. Ari, as he mentioned, we want to make this program as interactive as possible, and we would like residents to participate and interact, and that is why we have like a clash of the residents in our case discussion. One resident presenting and he'll be discussed by another resident. So without much ado, I think I would like to invite Dr. Subhash Konar from NIMHANS to start the program. So today's topic is going to be on craniopharyngioma. We all see craniopharyngioma very regularly, but each case of craniopharyngioma brings us several questions. And one of the important questions that every resident or junior consultant is faced with is what all I should do for the preoperative workup. How do I approach this case with respect to relevant neuroanatomy and radiology? So Dr. Subhash will give us an introduction on these topics.
I'm audible, sir?
Yes, request all the other participants to please
Yes,
mute their mics. Please mute their mics. Otherwise, there will be a lot of disturbance.
I am audible, sir. And
please go ahead. Please go ahead, Subhash.
Subhash, yeah, you're audible.
Yeah, my slides is seen, sir.
Yes, your slides are seen.
I'm not able to see. Yeah, thank you for introduction. Good evening to my respected teacher, my colleague and dear resident. So we are starting a virtual classroom. So it is basically for, already sir mentioned, it is basically for the resident and for the young neurosurgeon. Yeah. So today's topic is, it is a very common topic, but it's very complex from the anatomy side also, from the radiology side, the evaluation, and as well as for the management part. So I'm going to cover the anatomy, radiology, and the evaluation part. So the most important things in craniopharyngioma management, there are two types of approach. One is like microscopic approach, like traditional approach, and now all the craniopharyngiomas almost everywhere we are doing endoscopically. So both anatomy should be clear for the resident. So here on the slide, the first slides, I try to put both the anatomy parallel. One is microscopic anatomy, another one is endoscopic anatomy. The microscopic, first I'll just tell brief about the bony landmark. The microscopic anatomy, the bony landmark is, we have to the most important structure when we are doing a regular standard frontotemporal craniotomy, the most important structure we have to identify the anterocranial fossa. So anterocranial fossa, once we will identify the whole anatomy, like you have to orient around the ACP. Why? Because whenever we are doing a terional or frontotemporal craniotomy, our first structure we identify after frontal lobe retraction or without retraction is the optic nerve. So all the anatomy should be related. To the first structure is ACP. The bony landmarks are the anterior to that part is the planum, and then tuberculum, then pituitary fossa, then dorsum celli. So these are the important landmark or important bony landmark when you are seeing microscopically. The same anatomy we'll see, like if you are seeing a roof from down and from the top, the structures are same. Little bit changes, nomenclature is there, but the anatomy, the bony landmarks and the bony prominence are same. So this is the anterocranial fossa. There is a middle border, lateral border. You can see the optic foramina. Laterally, we'll see the supraorbital fissure, and the middle cranial fossa, if you'll go, we'll see the foramen oval, foramen rotundum. And if you just little bit zoom, you can see with the angulation, this is the optic foramina. So optic nerve will come medial to the anteroclinoid fossa. This is a part of the lesser wing of sphenoid. And if you'll see medial to optic canal is the carotid sulcus, or here internal carotid artery or clinoidal segment of carotid artery will be lying here. One more important structure I would like to mention is the middle cranial fossa. Here all the attachment will be there, different ligament. This structure also will be seen from the below. So here is the endoscopic view after doing the nasal stage and the standard like in pituitary we do. After that we'll see the most important structure is the pituitary fossa, and then down we'll see the clival recess, the paraclival laterally paraclival ICA, and then the same structure planum will be see first. So this is a sequence. First we'll see planum, then we'll see limbus, limbus sulcus, then we'll see tuberculum sella, then pituitary fossa. So here paraclival ICA at the clival recess. If you'll in the pituitary level will be a cavernous ICA. Other more important structure is the optic impression, optic nerve impression here. Below that the LOCR, lateral opticocarotid recess, and slightly down and lateral will be the medial opticocarotid recess, that same as MCP. That impression what you are seeing in microscopically, endoscopically will see the structure. When you will see the intraoperative view after doing the cellular stage, this is the keel of the sphenoid bone. After removal of the sphenoid ostium both side, we'll see the clival recess, then pituitary fossa, tuberculum sella, planum. So for craniopharyngioma surgery, the most important structure, because commonly it is a suprasellar structure, so commonly you have to identify the tuberculum sella. We can use navigation, but it's very useful to identify this bony structure. So now for the microscopic, after the bone, the microscopic, the traditional, our workhorse of our neurosurgical is cranial craniotomy. And after doing the cranial craniotomy, we'll see different corridor. This is very important to understand doing the craniopharyngioma surgery. So what I mentioned in the beginning, most important structure, the fixed, almost fixed structure is the optic nerve, ipsilateral optic nerve. We have to identify, then contralateral and chiasm. So there are different corridors. Is important for understanding the surgery of the craniopharyngioma. That is interoptic corridor, carotido-optic corridor, and lateral to carotid is carotido-oculomotor corridor. This corridor laterally, and sometimes if you want to go for a pure third ventricular craniopharyngioma, you can go to here translamina terminalis approach. And then this is the internal carotid artery ipsilateral. This is the bifurcation A1 and M1. A1, understanding the A1 segment of anterocerebral artery is very important with different perforators. And on the top of the chiasm, you may sometimes you get the ACOM, sometimes the anatomical variation will be there. So this is the basic anatomy. If you go more slightly lateral, more deep, you will see lateral to ICA, another bony prominence called posterior PCP or posterior clinoid process, and laterally we'll see third nerve. And if you'll open the Sylvian proximal, we'll see ACA, MCA. So another anatomy is important to know what are the position of the optic chiasm, because if you are using this type of different corridor like intraoptic corridor, anatomically before the surgery, the understanding the MRI is very, very important for suprasellar surgery. So commonly we have three main type: normal chiasm, prefix chiasm, and postfix chiasm. Prefix chiasm in 70% cases will get, postfix 70% normal, 9% is postfix prefix, and 21% postfix chiasm. That is important to understand in pre-op in MRI. Now I am going to the endoscopic view or endoscopic anatomy. So after doing traditional nasal stage, sphenoidal stage, after bone drilling, we'll see the down. This is the clival recess. Just above the clival recess, pituitary gland. This bluish is the cavernous sinus, both side. AICS means the anterior intercavernous sinus. This very important structure. CC is the chiasmatic cistern. So it is mainly a suprasellar tumor. So suprasellar, understanding the suprasellar anatomy is most important. So if you see a roof from the below, what we will see that two structures is going from the center is the optic nerve. This is the optic chiasm, and this is the chiasmatic cistern. So, and then one more structure. Once we'll cut the anterior intercavernous sinus, we'll see the pituitary stalk. That is the most important structure here, and it is like a trapezoid shape. This trapezoid is the chiasmatic cistern. So it has a anterior inferior border wall, posterior wall, lateral wall, and superior wall. So once we'll cut the anterior intercavernous sinus, so you can see better the superior part or pituitary gland with the whole pituitary stalk. That is very important for understanding for endoscopic craniopharyngioma surgery. So I'll go more detail and more zoom view. So BAM is the basal arachnoid membrane that will cover the different perforators and branches of ICA. So if you see the zoom view of optic nerve, SHA is the superior hypophyseal artery. It is the medial branch of internal carotid artery. So it is going medially. It has two branches. I'll show in a different slides. One is descending branches and one is ascending, supplying the optic nerve. So both the branches understanding is important. So here we can see more detail here that once you cut this arachnoid, we'll see IOM means interoptic membrane, interoptic arachnoid membrane, where this superior hypophyseal artery will go and make a vascular plexus around the pituitary stalk. So this is a lateral view with a 30-degree scope. MCM is the medial cavernous membrane. These are arachnoid membrane, and you can see how the branches SCA is coming and how the lower that's the callosal branch of SCA supplying below the optic nerve, and this is the pituitary stalk. Here, this DLM is the liliquous membrane, the diencephalic part of the liliquous membrane. If you go more posterior and lateral, like sometimes we may need to do a transposition of pituitary or a retrochiasmatic craniopharyngioma, we have to go lateral to pituitary stalk. So we'll encounter this anatomical structure. First is superior hypophyseal artery. If you go more deep, you can see it is arising from ICA, and you will see PCOM arising from here and going to the going and meeting P1 segment. So this is the PCP, posterior clinoid forces. This is the bony landmark, and optic nerve, optic chiasm, pituitary stalk. This is the diencephalic part of the liliquous membrane. So you can see the center part is the stalk, pituitary gland, the descending branch of superior hypophyseal artery, and that will both sides will come together and make the vascular arcade around the pituitary stalk. Here you can see how nicely they are making that vascular arcade, and this is the chiasm. Above the chiasm, this is the AIIMS complex and other perforator of AIIMS. So for going above, like if you're dealing with only infrachiasmatic cranium, you may not to cut this intraoptic membrane. But if there is a cellular, supracellular, and sometimes tumor will go to the third ventricle, in those cases, we may have to open this arachnoid and deal the tumor there with ACA like AIIMS complex and both side A1. So this the most important is that ACA, superior hypophyseal artery, two branches, descending branch, callosal branch or optic branch supplying the optic nerve and chiasm from below. So after the brief anatomy, I'm going to tell about little bit about radiological findings of craniopharyngioma. Grossly, there are 2 types, adamantomatous and papillary. The calcification is more common in adamantomatous. Mostly they are the pediatric tumor. In adult, we'll get most common is papillary. The adamantomatous is more lobulated and complex. They are multiple and large, and their third ventricular invasions are less common, and the boundaries will be irregular and adherent. And in case of papillary, they are single small. Their third ventricular invasions are more common, almost like more than 90%. They're regular, less adherent. So what are the classical radiological features of craniopharyngioma? So the most important things for a resident to diagnose radiologically pituitary craniopharyngioma is that sometimes in a small tumor, in a big tumor you may not see, but in a small tumor you will see the pituitary gland separately. That is the most important. So I'll show you some checklist, what we'll go through, how we'll proceed to read the radiology of craniopharyngioma. The most important points, just look for the pituitary gland separately. If it is seen, that means it is more likely it is a craniopharyngioma. Other is like solid cystic, most common. Cyst size is very large, small. It may be adamantomatous lobulated. Papillary will be round. T2 hyper, T1 IC2 hyper. Capsule usually enhanced on contrast. Calcification in bloom. There is a rule of 90 for adamantomatous type of cranio. 90 means 90% calcification, 90% cystic tumor, and 90% cases they enhance on contrast. So there is a rule of 90 for this tumor. And MRS rarely will do, but MRS if you do, lactate and lipid peak will be there. Perfusion, if you are doing, there will be a less perfusion. Other most important the aspect when you are reading the radiology is the relationship with the surrounding structure, like visual apparatus, relation to the optic chiasm, nerves, tracts, relation with the hypothalamus, very important from the morbidity point, from the surgical point, how much we should go for GTR, we'll go for STR, how significant is the infiltration. Then relation with the third ventricular floor. That's very important to understand the anatomy, the surrounding anatomy and adhesion. And obviously the circle of Willis, the anterior part, like ACOM complex, ACA, if it's a big tumor going laterally, so we may have to dissect the MC also. So what are the differential diagnoses? DD for craniopharyngioma, if you're seeing a cellular and supracellular tumor, the tumors are like RCC, Rathke-Sklett cyst, hypothalamic or optochiasmatic glioma, pituitary adenoma, or germ cell tumor. In RCC, there will be no calcification. They are generally homogeneous. Very rarely we'll see enhancement. In optochiasmatic glioma, they are generally interaxial. Calcification with cyst are uncommon. The enhancements variable. Sometimes we will see intense enhancement because commonly pathologically they are pilocytic. They will see. Sometimes we will not see. In cystic, changes will be there, necrosis will be there. Pituitary gland, in pituitary adenoma, like in a pituitary adenoma, we will not see the pituitary gland separately. Homogeneous, calcification cysts are very rare. Enhancement also homogeneous. In germ cell tumor, the most important is they are high cellular tumors, so there will be a diffusion restriction, homogeneous enhancement, and calcification and cysts are less common and small. So there are different classification of craniopharyngioma, almost like in literature, there are 26 types of calcification in a different axis, like vertical axis, in an anterior-posterior axis, in a coronal plane. So this is one of the famous and classification is Professor Yasser-Gil classification. It was introduced in 1990. It's very simple to understand. There are different type A, type B, type C, type D, type E, and type A. Briefly, I'll tell. Type A means it is a vertical axis classification from below up. So type A is intracellular. It will be inside the cella. Type B, intracellular and supracellular. Then type C is supracellular with extraventricular. Ventricular means third ventricle. The floor of the third ventricle is very, very important to understand or identify in MRI. And type D is intra and extraventricular, is going inside and outside. Type E is lateral extension, paraventricular, going to the Sylvian fissure. Type F is strictly interventricular. Now, one more classification by Professor Sami in 1997. He introduced almost similar type 1, 2, 3, 4, 5. Type 1 is intracellular. Type 2 is occupying the cistern. And type 3 and 4, that is slightly new here. So, type 3 means lower half the third ventricle. Type 4 is upper half the third ventricle. And when type 5 is reaching the septum pellucidum and the lateral ventricle. So this anatomy is very important to classify this tumor radiologically. And why this classification is required? Because based on your classification, based on your MRI understanding, you will select your approach, what corridor will use, how will proceed. So the most important things to understand is that draw a line from the base of the mammillary body, and you draw a line that will differentiate between suprachiasmatic, like this is the chiasm, this is the mammillary body. At the base of chiasm, if you draw a line, that will differentiate between suprachiasmatic and infrachiasmatic. Now, if you will draw a line from dorsum celli, and you'll see it will differentiate between infradiaphragmatic, like intracellular, suprachiasmatic, or infrachiasmatic or supradiaphragmatic. So this is the diaphragm attachment. So between one is the intracellular below the diaphragm. Now between the diaphragm and this horizontal line is the infrachiasmatic and supradiaphragmatic. Above is the suprachiasmatic. There is a 3A and 3B at the anterior border of the mammillary body. If you draw a vertical line, it is called suprachiasmatic and retrochiasmatic. Why it is important? Because based on the extension of the tumor, we'll select different corridor or we'll select our approach. So another most important is in relation with the hypothalamic involvement. There is one grading, like grade 0, 1 and 2. Grade 0 means if there is hypothalamus, there is no signal intensity changes in the hypothalamus, means hypothalamus infiltration is not there. Grade 0. There is in contrast of compression of the hypothalamus, that is grade 1. Grade 2, if you will see a grade 2 involvement, like hypothalamus is invaded in pre-op, that means your strategy will change. Like there is a definitely hypothalamic involvement is there. So now those are microscopic. Now Professor Kasam, he introduced a classification in 2008 for the endoscopic approach. Like he described, there are 4 types of craniopharyngioma, and his classification is based on the infundibulum and the pituitary stalk. So any tumor anterior to the infundibulum, if you are seeing, it's a pre-infundibular type. If the whole infundibulum is involved along the tuberoinfundibular craniopharyngioma, it's called transinfundibulum. Now behind it is retroinfundibulum, and one more tumor like pure solid cystic, or it's inside the third ventricle is intraventricular. So very simple, identify the infundibulum. Type 1 is anterior to infundibulum, pre, trans, retro or post, and interventricular. So this is one more paper. Nicely they describe the different origin of craniopharyngioma. Like craniopharyngioma A means it can arise from the dorsal surface of the pituitary gland. It can arise from pars tuberalis covering the infundibulum or pituitary stalk. It can arise from the subpial position within the neural tissue of the median eminence of hypothalamic nucleus. These are the different nucleus of the hypothalamus. Like if those are involved pre-operatively, so patients will have DI, patients will have sleep disturbance, different features, different clinical features will be there. And sometimes it can arise from the third ventricle. Based on this paper, this classification came in 2018. They told almost similar, cellular, supracellular, pseudo third ventricular. Pseudo third ventricular means their classification is based on floor of the third ventricle. Where there is a floor of third ventricle is not invaded, like a cellular supracellular type, but the floor of the third ventricle is not invaded. It is called pseudo third ventricular. Where there is a floor of the third ventricular is invaded, that is called secondary third ventricular tumor. And one more type is called infundibular tuberal, where along the axis of the infundibular and stalk, if the whole craniopharyngioma is here like this, it is called infundibular tubercle. And another is strictly third ventricle, like it is just inside the third ventricle and the floor is pushed down. So now in the MRI, before surgery, when you are planning for surgery, the most important things is you have to locate or identify the optic chiasm, because that will give you a clue that it is a strictly third ventricular or it is a pseudo third ventricular or cellular supracellular. What are the different type of impression we'll get chiasm? One is like non-distorted, pure third ventricular tumor. You can see in the MRI, the optic chiasm is not distorted. That means it is a third ventricular craniopharyngioma. It can be solid and cystic. Now, the chiasm can be compressed. Compress how? It can be compressed downward, like in case of pure third ventricular tumor, you will see chiasm compressed downward. This is the pituitary gland. Or it can be compressed anteriorly or forward, where non-strictly third ventricular, like a tubero-infundibular type, where chiasm may be strictly compressed. Or you can see in a different position in cellular supracellular type, pseudo third ventricular type, and different type.
Subhash, I think we'll have to.
I am just going faster. You have to, another important structures you have to understand is the angle between mammillary body and its relationship with the topography. This is the, it's called mammillary body angle. How we'll draw the angle? If you'll draw a line along the base of the mammillary body and along the floor of the fourth ventricle, normally it's 50 to 60 degree. So if the two types of craniopharyngioma we can identify radiologically before, if it is obtuse or hyperacute, like if it is coming from the above, it will compress, so angle will be obtuse, or it is coming from anterior, it will press. So there is another important structure, what I was telling, the checklist. When you are reading the radiology of craniopharyngioma, we should try to identify first the floor of the third ventricle, chiasmatic cistern, pituitary stalk, hypothalamus level, mammillary body angle, optic chiasm distortion, and tumor shape. I'm not going more detail in this, but these are the structures you try to identify, and then we'll get the what is the type of craniopharyngioma you are dealing. Another important thing is adherence with the hypothalamus. This paper they mention there is a different grade of adherence: mild, moderate, serious, severe, and critical, and that based on the morphology. So how the craniopharyngioma, the most important things and still controversial, that should we go for GTR or we'll go for NTR, or we'll go for subtotal resection with adjuvant. So this is the most important. What I found, this magenta color you are seeing, this is the adhesion level. Like in cellular type, you will see in the cellular gland, sometimes we adhere with the superior dorsal surface of pituitary. Sometimes it will be adhered to the surrounding structure. Sometimes it will be adhered to the entire thickness of the third ventricular floor. And then another type, it will be with the third ventricular floor with the lining wall of the third ventricle, and sometimes like global, like whole attachment. And what are the pattern of attachment? Pattern of attachment, sometimes it will be a pedicle type, only little bit attachment, sessile type, small attachment in that infundibulum, cap-like in the superior surface, ring-like. This is the more typical of tubero-infundibular type, where the mid-third will be the hypothalamus, and then ring-like, there will be a adherence, bow-like and circumferential. Different type of strength of adhesion, like loose type, where there will be arachnoid plane or arachnoid plane, so it will be loose type adhesion. Tight means only small area along the stalk it will be attached. Fusion means both the plane, the neural tissue and the tumor tissue is fused, and sometimes it will be replacement, means like that neural tissue will be replaced with the tumor tissue. So in this type of cases, there will be no plane, it will be difficult to achieve GTR. Now, brief about evaluation. When we suspect, we should know that craniopharyngioma has a bimodal distribution, young and old, commonly presented with headache, visual symptoms, developmental issue, and psychiatry issue. Endocrinal evaluation is very important, because the other common supracellular is pituitary, where the pattern of hormonal involvement is totally different from cranio. Here, GH involvement is most common. That's why patient present with growth retardation, like almost 75%, followed by gonadotropin, followed by thyroid and cortical deficiency. Other things like depend on your stalk and hypothalamic nucleus involvement, DI. That is important. cortisol thyroid deficiency, perioperative stage coverage, like if it is deficient, steroid replacement. Another is vision involvement, just document the visual acuity field fundus. 80 to 90% cases, they will be having visual field deficit. Neuropsychological evaluation is very important in case of craniopharyngioma. Another important things when you are sending the biopsy is a histomolecular workflow, like two types I told. Two types. In adamantomatous type, we should go for beta catenin, and it is a nuclear accumulation of small epithelial, and then we should look for any CT NNB1 mutant, it is there or not. In papillary type, BRAP gene sequence, because it will help in managing the patients. And in now even some papers have come with methylation profile of classical craniopharyngioma. To summarize how we'll work up, so most important thing is the understanding the radiology, understanding the MRI. So CT and MRI understanding, hormonal profile for the management, perioperative period, post-op, ophthalmological evaluation to prognosticate the patient, input-output charting to diagnose diabetes insipidus, weight monitoring for 3 days before surgery, after surgery, neuropsychological evaluation, because sometimes patient present with neuropsychological symptoms, and routine pre-op investigation. Thank you.
Thank you, Dr. Subhash. I think he gave a very extensive anatomy and imaging points, and I'm really impressed that many of the points which have been told are very, very important for management as well as from residents' perspective. Should be aware for evaluation as well as when you had to deal with a patient of craniopharyngioma. I think we'll just take one comment from Dr. Deopujari. Sir, you would like to tell something regarding from experience. What is the important anatomy that we should remember while operating or while managing? Then we'll go to case discussion. There are no questions in the chat box from the audience. So I'll just request a comment from Dr. Deopujari if sir is there. I think sir is muted. Ranjith, then we'll go to the case then. Dr. Ranjith?
So, Ari, I think we'll go to the first case.
Yeah, please, you start the case.
Yeah, so...
and like I said, the presenter will present the case in 5 to 7 minutes. And then we'll take the discussion by the discussant, and then questions from the, and then panelists, and then question from the audience.
Okay, I would like to call upon Dr.
There
Prakash.
is a question in the chat box.
Yeah, we will answer that. So I would like to invite Dr. Prakash, who's a final year MCH Neurosurgery resident from All India Institute Medical Sciences, Delhi. And he has been guided by Professor Shweta Kedia, who's an experienced neurosurgeon interested in pediatric neurosurgery and radiosurgery. And I think without much delay, I would ask Dr. Prakash to present the case. And Dr. Mehul from Christian Medical College, Vellore, would discuss this case once he has finished his presentation.
Good evening, everybody. So I would like to start the case presentation. Before I start, I just wanted to confirm whether I have to complete the entire management that was done for the patient, or we stop at the level of imaging and pre-op planning.
No, no, Dr. Prakash, you will present up to the case details and allow the discussant and the panelists to comment on the case, intricacies and challenges. Then we'll take questions from the audience, and finally you will tell what you have done.
Yes. Thank you, sir. So to start, we have Master A. He's a 10-year-old boy studying in 4th standard. He had presented to us 1 year back with complaints of headache and vomiting for 1.5 months. At the time of presentation, he did not have any visual complaints. He had no history of weight loss or weight gain, no history of any change in scholastic performance, no history of any excessive urination, no history of lethargy, reduced appetite, cold or heat intolerance, and no history of change in behavior or personality. His primary complaints were only of a headache, which was a severe holocranial headache, and projectile vomiting, which had increased in frequency for the past 1.5 months. With these symptoms, he had presented to us in the emergency. And in the emergency, during the evaluation, he was conscious, oriented to time, place, and person. He had a visual acuity of 6/6 in both eyes, but the fundus showed a grade 2 papilledema, and pupils were reactive, and he had no other cranial nerve deficits or sensory motor deficits. So, on examination, he had a height of 136 centimeters, a weight of 38 kilograms, a BMI of 20.5, which fell in between the 50th and 75th percentile for his weight for age group. So, this is the admission CT scan. So we can see in the CT scan that there is a hyperdense lesion involving the cells, suprasellar and third ventricle, with peripheral calcifications, and there is dilatation of the lateral ventricles, so asymmetric dilatation of the lateral ventricles. So we can see in this particular cut that there is is the video visible? So coming on to the course in hospital, initially we had, since the patient had presented with an acute raised ICP features, we had performed a right occipital medium pressure shunt, and followed by we had performed the hormonal evaluation, which showed a slightly low FSH, but the other hormones were within the normal limit. He didn't have any cortisol, thyroxine, or IGF-1 deficiency at presentation. Subsequent to the shunt, we had performed the preoperative MRI. So in our MRI, in the axial T1 sections, we can see that there is a T1 hyperintense lesion involving the suprasellar and third ventricular region with peripheral cystic changes. And this is a plain T1 sequence. Coming on to the T2 in the coronal, we can see that again there is a hyperintense lesion. And in the coronal, in the T2, we can see that the peripheral cystic lesions are also hyperintense. Then on the contrast MRI, we can see that there is a rim enhancement of the lesion, the peripheral rim enhancement with the sagittal image is also showing that there is a peripheral rim enhancement. Also, the image shows that there is a displacement of the hypothalamus superiorly as well as the chiasma anteriorly. So these are the still images showing the relevant anatomy. So we can see here in the T1 contrast image on the sagittal that there is the hypothalamus is displaced superiorly, and we are not clearly able to make out all the structures of the hypothalamus. The lesion appears to be primarily in the third ventricle, and it is pushing the chiasma anteriorly. So with this, we had come to a provisional diagnosis that this is a third ventricular craniopharyngioma.
You would like the discussant to discuss now?
Yes, sir.
Yeah, please.
Dr. Mehul, you can give your comments what you would do for this case.
Good evening, sir. Can you hear me?
Yes.
Please go ahead.
Yeah.
Yes.
So 10-year-old boy presented with features of raised intracranial pressure, that is headache and vomiting for 1.5 months. And on examination, there was bilateral papilledema, grade 2 papilledema. And CT brain plane, which was done immediately, showed a large suprasellar lesion, predominantly cystic lesion with peripheral calcification, with upstream dilatation of ventricles. So in that situation, my probable diagnosis would be a cystic craniopharyngioma with hydrocephalus, and subsequently he was shunted. And post shunt, we can see in the MRI sequences that the ventricle size has come down, and and the cyst wall is peripherally enhancing. So now hormonal assessment was done, which showed that hormones were within the normal limit. So I would like to go ahead with surgery, that is right subfrontal approach and excision.
Any challenges you anticipate? Any other alternatives you would like to discuss?
Yeah, so you can see in the imaging that the chiasm is pushed anteriorly and hypothalamus is displaced superiorly. So I think we may opt for subtotal resection, like with taking care of the chiasm as well as hypothalamus, because his endocrine function is intact. So we don't want him to land up in post-op morbidity.
I think does the presenter have some questions to ask, or shall we discuss our questions or our queries?
So I wanted to know, are there any other approaches that can be used other than a right subfrontal for this patient?
Yes.
We can go endoscopic transnasal approach can be done.
Okay, so we'll take opinion from panelists, Dr. Deopujari and Dr. Dilip, and I'll also request Dr. Ali, who will be the next speaker later, to comment on this. Then we can discuss the various options. Sir, first Dr. Deopujari, sir.
So, Hari, I think one of the first things I would like to mention is we do not have an adequate coronal picture here at the level of the sella. I do not see pituitary stalk here, and I am a little careful about displacement of the hypothalamus while describing this. One thing is for sure that this patient presented without any visual field defect. So one of the things to remember is when you have no visual field defect and you have papilledema in a patient with such a large tumor, without seeing even a radiology, you can say that this is most likely an intraventricular or at least a retrochiasmal tumor.
Yes, sir.
And you have to think about
That's what I was
approach accordingly. The second thing I would do, and which we have described, published also, is that when I see a predominantly cystic tumor, I would not treat the hydrocephalus first. My way of treating hydrocephalus will be simple. I would put an endoscope, drain the craniopharyngioma cyst, and the hydrocephalus takes care of itself. And you put a reservoir in the cyst and you can drain it as and when possible till you have completed all your investigations and decided about your definitive way of treatment. Now that we are at this stage, that we have to decide the second stage of the treatment, patient is 10 years old, patient has no diabetes insipidus. So it is our responsibility for this patient that we should keep him hormonally intact as far as possible. Try to do an excision to some extent and then use the complementary methods. As he is 10 years old, we can probably resort to other complementary methods as well. In this particular patient, as we are dealing with a retrochiasmal tumor, I would like to see more images to confirm that. My approach would be of two types. As it is predominantly intraventricular or retrochiasmal, you can either consider a lamina terminalis approach or you can consider a transcallosal approach. I think by draining the hydrocephalus, we have taken away we have reduced the possibility of using a transcallosal approach, because through a small ventricle, it is always more damaging to do an intraventricular surgery. So it is probably my preference in this particular case to do a right pterional craniotomy, because from frontal craniotomy, you will encounter the optic nerves first, and when you go from the side, or at least a little bit of side, you are more likely to get into the lamina terminalis and get to the lateral and posterior part of the tumor as well. So that is my preference.
Thank you, sir.
Prakash, can you take, sorry, Dr. Ari,
Yes,
Prakash, can you let the whole video of the coronal, so
yes,
you can
yes,
go back to
yes.
the slide so people can actually
Yes.
then review the MR images whenever
Yes.
they want to, right? Okay,
Yeah, I was about to ask Dr. Prakash, you can run the video so that you can see. Dr. Panikar, sir,
Yeah, Ari, thank you.
how would you your thoughts
Okay,
on management?
I
How
think
what
I think very interesting case. As Dr. Deopujari mentioned, I think the key point is that this child has presented with raised intracranial pressure and not with visual or endocrine disturbances as a primary feature. Large cystic tumor, predominantly essentially a cystic tumor with a peripheral rim of solid tissue located intraventricularly. Yeah, the sagittal section. If you could put the sag section, yeah, you can go to that single image. I think that showed, yeah. You can see the pituitary below, which is separate. You cannot see the stalk though in this, but I'm sure if with better images, you may be able to see the stalk. Now, two issues. The immediate priority for management with this, if this child presents in the emergency, is to manage the intracranial pressure. And I agree with Dr. Deopujari that I think the best way to reduce intracranial pressure is to drain the cyst, which can be very easily done through a transventricular or a small craniotomy or even an aspiration, which will allow the cyst to decompress and will relieve the hydrocephalus. The definitive management of the tumor, given the fact that
sorry, can others please mute their mic? There is some disturbance coming. Please, sir, please go ahead.
Yeah. The definitive management is again is again a point of discussion here. I agree with Dr. Deopujari's suggestion of a translaminar terminalis approach, because that is probably the most direct route to getting into the tumor in the ventricle. But my preference would be an anterior interhemispheric approach rather than an approach from the side, which even though when you do an approach from the side, even a lateral subfrontal approach, you would see the lamina terminalis be able to open it, but then there is a part, ipsilateral part of the tumor wall that is adherent to the ventricular wall that can be blind to you. So I prefer the anterior interhemispheric approach, which gives you a direct visualization of the entire length of the tumor. And given the fact that this tumor has a good plane, there is no edema in the brain around that, as you can see in the T2 image. It should be possible to dissect the capsule of this tumor off the walls of the ventricle and achieve a near total or a total excision of this tumor, preserving the visual function and very likely the hormonal function as well. So this will be my approach for this.
Yeah, thank you, sir. Dr. Ali, if I can ask you, so with such a large tumor, how like what will be the intent with this? Suppose I mean, it's interesting to see that different approaches can be considered for the same tumor. Now, if whichever approach we take, what should be the intent when we go in for this tumor? What should be like? How much we should decide to remove or leave behind? That should be the plan.
Yeah.
And your comments on how you would approach.
Thank you, Adi. Can you hear me?
Yes, please go ahead.
Yeah. I think Dr. Deopujari made a very valid, pertinent point there that the child has come with only headache, raised ICP, and is visually intact, and endocrine also is intact. So I think the key is here to preserve endocrine function, especially in children. I think it's very crucial because the growing phase.
Your voice is slightly less. I'm not sure if is Dr. Ali audible to others.
No, yeah, I was sir. आपकी आवाज कम है.
Yeah, Dr. Ali, your voice is not well heard.
Okay,
You're
is it better now?
Yeah, better.
So I was mentioning that as Dr. Deopujari very pertinently pointed out, this child has come with no visual deficits and no endocrine problems. So I think the key is surgery should not confer any additional deficits, visual for sure, and endocrine as far as possible. Cystic tumors are often more challenging to remove than solid because the cyst sometimes is stuck and there is a chance of traction-induced injury. Hypothalamus doesn't seem to be involved because it's a big size of the tumor. It seems to be pushed, but there is no signal changes, at least in these images. So may not be direct invasion, but you can't rule that out. So I would say in short that you should try and remove it as much as possible, but don't go to the extreme of causing either stalk damage or hypothalamic injury. Hypothalamic injury can be unforgiving. So I would say that try and remove as much as possible. In cystic, it may not be that easy. So leave few bits around, and then you can always back it up with adjuvant therapy. Outcomes oncologically in subtotal resected with backed up, and now you have proton therapy, as good as radical resections.
Thank you, Dr. Ali. Any questions or
I think
queries?
one of the things which none of us have mentioned, I would just allude to that. None of us have mentioned to endonasal endoscopic approach.
Yes,
And
yes,
the
I was
main
about to
reason
tell
for
that, sir.
that,
I was about
the
to tell
main
that.
reason for, yeah,
Yes, sir, please go ahead, sir.
main reason for that is that sella is not enlarged. We do not have a clear delineation of where the stalk is. And I think once you have decided that we are not going for a radical excision, then I think we are not depending on an approach where we are not sure if we will be able to preserve the hormonal function.
Thank you, sir. Any questions from the audience? Any queries, questions? I didn't see anything in the chat box. If anyone wants to ask a question, please go ahead.
I sir just wanted to know from Dr. Ali, how frequently do they put in a patient who's presented with hydrocephalus? How often do they put a pre-operative to buy the time kind of a thing, like Umaya sort of a thing for cyst tapping or drainage?
So we would rarely do a.
Sir, आपकी आवाज धीमी आ रही है.
I think there is some problem with my mic. Is it better now?
Hey, better, Dr. Ali. Go ahead.
Okay, so I would say that we would rarely resort to a shunt procedure prior to surgery. I think Dr. Deopujari has a unique way of dealing with this, but we would probably use take the patient up for surgery directly, definitive surgery, tap the cyst, decompress it, and then excise or whatever subtotal resection. But I think if it's an extenuating circumstance, then you have to put in maybe an EVD and take up the patient.
Yeah. Okay. Okay.
Yeah. There is a chat box query. Not sure by V. Endoscopic transcortical transventricular approach with. Can you ask the question? I'm not able to recognize the person, Miss Dr. V. You can ask if you can unmute yourself and ask the question. I am not. I think he is not asking. So
I think, but that has been partly answered. I think with Dr. Deopujari.
Yeah. Okay. So we'll go to the treating team to tell what they have done.
They've done. Yeah. Yes.
Please
Prakash,
go ahead.
please continue.
Yes. So to continue, we have discussed the approaches that were possible for this case from the panel. The approach that we had taken in this patient was a bifrontal interhemispheric transbasal approach. And so this is an operative video of the same that was done. So we have done a bifrontal craniotomy and ligated the falx. And we are doing the arachnoid dissection to expose the anterior skull base and the optic nerves in the tumor. So here we can see the right optic nerve being exposed along with the tumor bulge. So after this, the tumor cyst was tapped and motor oil fluid was drained from the cyst. And this resulted in the expansion of our working corridor and the tumor became a little lax. And subsequent to this, we were able to do an arachnoid dissection of the tumor. So this tumor had a very good arachnoid plane and it was being dissected off the surrounding structures relatively easily. So wherever possible, we tried to avoid pulling the tumor and did a sharp dissection so that we do not cause any traction injury. So we can see that the tumor was solid cystic and it had chalky white calcifications.
So you went interoptic or you went translaminar terminalis?
So interoptic as well as translaminar terminalis. The tumor was bulging into the interoptic corridor, but then majority of the tumor was retrochiasmatic. So translaminar terminalis approach was used for the accessing the third ventricles. So we had managed to achieve, since the tumor was having a good plane and there was not much adhesion or infiltration towards the neural structures, we had managed to achieve a gross total excision. So this was the post-operative scan of the patient. So we can see that the tumor was almost completely removed and there is a mild pneumocephalus, but otherwise there were no other gross hematoma in the scan. And this was the histopathology report of the tumor. So it was a adamantinomatous craniopharyngioma with positive beta-catenin expression. And these are the histopathology slides showing the tumor cells along with keratin whorls and the reticular matrix. And this was the positive beta-catenin expression. Okay, so coming on to the post-operative course, so perioperatively we had consulted with pediatric endocrine and started the patient on stress dose steroids on the day of the surgery, which was continued post-operatively. The post-operative hormone profile was having mild FSH was slightly low, otherwise the rest of the hormone profile, the FT4 was normal. TSH was slightly low, but as such the patient did not require a thyroxine supplementation. And the cortisol was at 6 in the immediate post-op, and patient was then discharged on Hyson, and that was subsequently tapered off during the follow-up. A patient also developed triphasic diabetes insipidus in the postoperative period. In the initial post-op day 1, the sodium had gone up to 149 and did not require any treatment for that other than hydration. But subsequently, he had developed a fall in sodium to 123, which was corrected and gradually picked up with fluid restriction to 132. And by post-op day 10, he had developed hypernatremia, at which point we had to start him on desmopressin supplementation. Patient also had a diminution of vision in the left eye in the postoperative period, which had reduced to a finger counting at 4 feet and had gradually improved to 6 by 60 by discharge. He was discharged on Hyson 2.5 mg thrice a day and Mindrin 0.05 microgram twice a day. So this was the follow-up MRI that was done around 4 months later, which showed that there was no significant residual tumor, no enhancing tumor, and the third ventricle was almost in normal size. And in the sagittal scan, we can see that the hypothalamus has essentially been restored to its almost to its original anatomy. So we had continued following up the patient. So the things that we had looked for in the follow-up were the pituitary function, the visual outcome. This patient had a visual deterioration post-operatively, and the hypothalamic dysfunction and scholastic performance. So the patient had managed to did not have any significant hypothalamic dysfunction. His hormone profile remained within normal limits. He had been this follow up had happened around 2 months back. He had been completely tapered off the steroid supplementation, and his thyroxine and levels were normal. His IGF-1 levels were also within the normal range for age, and his serum testosterone was also within the normal range. Patient had increase in height of around 2 centimeters in 1 year, but however his weight had remained the same. His visual acuity in the left eye had improved from 6 by 60 at discharge to 6 by 36 with a temporal field cut. And the right eye it remained 6 by 6. He had restarted attending his school and is currently in 5th standard and has an average scholastic performance.
Yeah, thank you. Anything you would have done differently after seeing that there was a visual deterioration post-op? Retrospectively, anything you think you could have done differently?
So the approach that was taken is bifrontal subfrontal approach. So in this approach, we encounter the optic nerves first before encountering the tumor. So if we had taken a more lateral approach like a pterional, it's possible that we may have not injured the optic nerve. But even during this surgery, there was not a clear point in time where we had realized that we had ended up injuring the optic nerve.
Thank you. Any questions or any comments from the panelists? And then we can go to the next case, if there are any. Okay. Thank you. I think we'll go to the next case, Dr. Ranjith.
There is one hand raised, so.
Yeah, please go ahead.
Dr.
Mukherjee has asked, was it okay by translaminar approach? Translaminar terminalis approach? I mean, not clear the question. I mean, any
No,
other
I think the question he's trying to ask is, could this have been done through the translaminar terminalis approach? So I think yes, it is. Could have been done, as Dr. Dilip Panikar and Dr. Deopujari also commented. We could have operated on this patient through the translaminar terminalis approach also.
I think Dr. Prakash said they used both corridors,
both
interoptic
corridors,
as well
yes.
as translaminar terminalis. Though the operative video showed predominant time, most of the times was interoptic. Maybe that's why there was confusion. But he said that they used both the corridors.
Yeah, can I make a comment here?
Please,
yes,
sir.
See, the problem with the problem with these tumors is that the retrochiasmatic tumors is that it pushes the optic chiasm forwards and
Correct.
downwards.
I was
the
about
bulk.
to say that.
So when you have this tumor, you might be able to see it through the interoptic space, but it becomes a very, very narrow corridor to work in. It's probably easier to first approach the tumor through the lamina term. Takes you away from the optic and you can work without manipulating the chiasm or the nerves. And manage to excise some of the capsule. The interoptic approach from below the chiasm can be used as a complementary approach. But rather than to take the tumor, it's probably better to use that to deliver the tumor upwards towards the main cavity from which the surgeon can work. So this is what I probably feel would reduce the probability of stretch or any kind of injury to the.
Yes, I think that's a valid point. In fact, I wanted to make the comment in the pre-op MRI itself. If you notice the pre-op MRI in that SAG images that he showed, the A2s are pushed anterior. They are in fact anterior to the tuberculum sella. Meaning the ACOM complex is anterior to the tuberculum sella, which is a surrogate marker for the chiasm, and that itself was giving. You can see in this. You can see that the A2, the ACOM complex is almost at the level of the tuberculum sella, which means the optic nerves are stretched and pushed anteriorly. And so when you come from the beginning, of course, in this case, at least they had a gap between in the interoptic corridor. But if it was too small, then it would have made dissection as well as access difficult. So that was one point I think we can look before going
I
in. We
can
can look
comment.
at all the park anatomy to choose the best option.
Sir, one small comment, sir.
Yeah, please.
Subhash here, sir. Dr. Subhash here.
Yeah, please go ahead.
Sir, here, sir, what we are seeing here, what you commented, that the chiasm is pushed anterior and down, and
Yes.
pituitary gland is seen, and the initial part, maybe if you'll see the other search
Yeah.
cut, the stalk,
Yeah,
the beginning of the stalk
even if
is
the
seen.
chiasm is not seen, we should look at the vessels.
Yes, sir. Yes, sir.
A2 complex,
Sir.
which will give
So,
a surrogate marker as to where the chiasm
yes, sir.
is.
So approaches should be like what Deopujari sir told, either like
No,
endoscopic.
there are many approaches. We are discussing like what are the points we should take in
Yes, sir.
consideration. We can choose.
So,
Yes.
what interhemispheric approach sir told, or endoscopically or microscopically,
Yes. Yes.
that is better in this case.
Yeah. Can we go to the next case? I think this is a good case and good a lot of learning points for all of us, and nicely done. Of course, can we go to the next case, please, Dr. Ranjith? Can you introduce?
Yeah, the next case will be presented by Dr. Kumar Mehul. He's a final year MCH Neurosurgery 3-year course resident from Christian Medical College, Vellore, and he's been guided by Dr. Anand Abraham, associate professor and person interested in pediatric neurosurgery, working in our institution. And we will present a slightly different case with a different approach, highlighting some aspects of management. So, Mehul, you can start.
Good evening, sir.
Can I make it full screen? Full screen? This.
Yes, sir. Hello. Good evening, sir. Can you hear me?
Please go ahead.
Yeah, we can hear. We can hear you.
Yeah. Can you make it a slideshow, full screen?
Can make it a slideshow.
Yes, sir.
Yeah, that's good.
Yeah. I request all others to mute, please.
Yeah, it's good now.
Good evening, everyone. I am presenting a case of a 3.5-year-old boy who had presented in March 1993 with headache and vomiting for 1 month, followed by 1 episode of loss of consciousness. His parents took him to a local hospital, and a CT brain plane was done that showed suprasellar cyst with hydrocephalus. He underwent emergency right parietal VP shunt, followed by right frontal craniotomy and subtotal excision in April 1993 at Ranchi. Following the surgery, his sensorium improved, but failure to thrive persisted. Subsequently, he presented to CMC Vellore in February 1994, that is 10 months after the previous surgery, with complaints of failure to thrive for 2 years, abdominal distension, anorexia, and lethargy. On examination, his GCS was 15. He was emaciated. He had ascites with bilateral communicating hydrocele. His abdominal girth was 64 centimeter. His visual acuity and fields were normal. He had primary optic atrophy bilaterally. Pupils were equally reacting to light, and he did not have any other neurological deficit. So my question will be, what will be your diagnosis? And do you think that the ascites which he had is related to his present problem? And how would you have managed this patient if he had come to your center first time?
Dr. Prakash, you would like to?
No, do we need before that? Do we need the scans?
Okay, no. Let him first comment on whether the ascites is related to his present problem. Then we will show the scans.
So the current patient has come after subtotal resection with features of failure to thrive. So this could be because of a hypothalamic injury that occurred during the surgery, which resulted in the patient not having a good feeding drive post-operatively. The ascites could be secondary to severe hypoproteinemia due to malnourishment, and so that would be my working diagnosis so far. Sir.
Mehul, now show him the image when he came to us.
Yes, sir. So hormonal assessment was done, that was normal, and ascitic tap was done, which showed a cluster of choroidal cells, but there were no features of malignant cells. So the CT brain with contrast was done in January 1994, which showed a large suprasellar cystic lesion with peripheral calcification and upstream dilatation of ventricles. The tip of the right parietal VP shunt was seen in situ in the right lateral ventricle. So our diagnosis was regrowth of residual tumor with VP shunt dysfunction. So after seeing the scan, what will be the management options?
Prakash?
So there is a large. So can we go back to the scan?
Yeah.
So there is a large intraventricular tumor which is predominantly in the third ventricle and extending to the lateral ventricles. Are there other views available?
We have only these views because the scan was done in 1994. So
yes. So sir, with this working diagnosis that this is a recurrent craniopharyngioma, we can plan for a redo craniotomy, sir, and pterional translaminar terminalis approach to approach this tumor.
Okay.
No, 1 minute. Mehul, before that, now we would like to ask Dr. Dilip Panikar what he would do for recurrent cystic craniopharyngiomas. Dr. Dilip Panikar? B is not there now. Dr. Deopujari, what would you do for a recurrent cystic craniopharyngioma?
Do we know for sure it is a craniopharyngioma?
Yeah, the outside diagnosis was they had got a histological diagnosis they came with, saying it was a craniopharyngioma.
Because ascites after a shunt is fairly common in opticohypothalamic
OCG,
glioma
yes.
rather than craniopharyngioma. So I would like to make sure that we have the correct diagnosis there. The second thing is we need to see the other views. I think with only nowadays we are in a situation that looking at only one plane we cannot decide on the approach to the tumor. But this certainly needs another attempt at surgery before the patient is asked to get complementary treatments. And what is the age of the patient? I missed that.
He was around 5 years. 5 years when he came.
So we will have some limitations, but I think we still would like to do a subtotal surgery in this patient. But I would certainly like to see either an MR or at least a CT in at least 2 dimensions or 3 possibly.
Dr. Yogi, I think you might have also managed patients in 1994 and you might have had to do with these kind of axial scans alone. So that's all was available for us.
If we are going to do only on the basis of that, I would do a transventricular, subtotal excision of this tumor.
Tumor, yes. Dr. Dilip Panikar?
Sir is not reachable. I think with the limited imaging, I would also, I think we didn't discuss this in the last case also. Sir would prefer endoscopic. Still interhemispheric transcallosal transventricular approach, because with this, whatever, we are not even seeing the basal cuts to see how much of tumor is there in the cellular suprasellar region. So without seeing, we are talking about craniopharyngioma without having a cellular suprasellar imaging. So it's difficult to comment. But with whatever we see here, I think entering, I would consider an interhemispheric transcallosal, transventricular, or transforaminal approach to consider decompressing the cyst as well as excising the wall. We do not know with this imaging what is the tumor load at the cellular suprasellar level. So with the In the absence of that information, we cannot. I would not consider a basal approach for this patient. And
this
I'm
patient
still,
also, I think it is probably possible to do a transventricular because the ventricles are still fairly.
yes, sir.
I mean, the frontal horns are fairly large. Yeah.
Yes.
Dr. Rakesh Gupta has asked whether we can consider biventricular stent because the hydrocephalus is there. I would think that once we decompress the cyst and take the wall, the hydrocephalus will settle. And in the same approach, we can do a septostomy so that avoids another hardware, need for another hardware.
Yeah.
No, and we also need to remember that this patient has had a shunt-related ascites, so which needs to be taken care of.
Yes.
So
now, if we can open up the natural pathways,
yes,
then the need
then
for
we can
shunt
remove
will
the
come
shunt.
down.
Yeah. Okay, Mehul, now you want to tell us what we have done?
Yeah. So CT guided stereotactic aspiration of the cyst was done through the right frontal burr and placement of Pudens reservoir was done. Around 50 ml of xanthochromic fluid was aspirated, and the right parietal VP shunt was removed. CSF taken during the procedure did not show any growth. This was done on 22nd of February 1994. So post-operative imaging showed reduction in the size of the ventricles and the cyst, and the reservoir tube tip was found in the cyst cavity. And subsequently, the ascites was resolved. The abdominal girth reduced to 44 centimeter from 64 centimeter. And he had developed panhypopituitarism, and he was started on hydrocortisone 10 mg twice daily, thyroxine, and he was advised growth hormone therapy, but unfortunately they could not afford it. And subsequently, he underwent conventional fractionated radiation therapy at CMC from 27th Feb 1994 to 14th of April 1994. So he came to us for follow-up 8 months later after the previous radiation therapy. And this was the scan. So the scan shows that the cyst has been adequately decompressed, and there is a small residue in the basal cistern. The ventricle size has remained the same. Then, due to his personal reasons, he was lost to follow up with us, and he presented to us 8 years later. And at that time, he did not have any visual disturbances or any features of raised ICP, but he had stopped going to school after 7th standard due to poor scholastic performance. He had short stature and delayed puberty, but visual acuity was 6/6 in both eyes. And the replacement, he was on replacement, but the doses of thyroxine was increased from 75 to 125, and testosterone injections were started subsequently. This is a scan when he came to us in 2002. And this scan also shows that there is a stable residue, and the cyst is adequately decompressed, and the ventricle size has remained the same. Subsequently, 2 years later, he came back for follow-up, and here also we can see the size of the residue is the same, and the ventricle size also remains the same. This was the MRI done in February 2022. Here we can see the residue. The ventricle size is almost remaining the same. There's no increase. There's no cystic recollection. So in 2025, he presented to us primarily with the complaints of walking difficulty for 3 years, and he was diagnosed subsequently with bilateral genovalgum, and he underwent right distal femur and proximal tibia corrective osteotomy in August 2025. And at this time, his visual acuity was 6/9 in both eyes. Although he was able to take care of himself, but he was unemployed and unmarried, and he was continued on replacements. This is an MRI which was done in July 2025. This MRI also shows the same stable residue, and the ventricle size is also remaining the same. So here I've tried to show all the images right from the second surgery till 2025. So this is the first image, that is 10 months after the first surgery, where we can see a huge suprasellar lesion, cystic lesion with the peripheral calcification and hydrocephalus. 8 months post radiotherapy, there is a small stable residue with decrease in the size of the ventricles, and this continued 8 years. This remained the same in after 8 years, 10 years, and in 2022 and 2025. So on a 21 years of follow-up, on 31 years of follow-up, the size of the residue remained the same. The ventricle size also remained the same. So coming to the strategies for management of recurrent cystic craniopharyngioma. So we have two options. Either we can go ahead with repeat excision of the wall, or Ommaya reservoir placement after cyst aspiration followed by radiation therapy. As we see that in cystic craniopharyngiomas, gross total resection of the cyst wall may not be feasible due to the adherence to the vessels, optic apparatus, and third ventricular wall. And as the cystic component tend to recollect rapidly within few weeks of the excision or aspiration and Ommaya reservoir placement, it is imperative to administer early radiotherapy in patients with cystic craniopharyngiomas. So indications of Ommaya reservoir placement is the recurrent cystic craniopharyngioma that is not eligible for gross total resection, such as those cases which involve the pituitary stalk, hypothalamus, or optic pathways, and primary cystic craniopharyngioma that are not suitable for major surgery. And the rationale for this Ommaya reservoir placement is that it is relatively quicker and safe procedure with stereotactic guidance, and it offers opportunity for cyst aspiration for recurrence. Also, we can directly inject chemotherapeutic agent or local irradiation into the cyst cavity. And definitely it needs to be supplemented with early radiation therapy. Then it is seen that there are similar rates of tumor control and survival rate in patients undergoing planned gross total resection and those undergoing planned subtotal resection followed by adjuvant radiotherapy. And stereotactic conformal radiotherapy provides superior long-term preservation of neurocognitive and endocrine function compared to the conventional radiotherapy. So this is one of the study done at our center, and it showed that 18.5% of this recurrence was seen in the early post-op period following the surgery. So again, stressing on the fact that there is a need for adjuvant radiotherapy, upfront adjuvant radiotherapy.
Okay, thank you. One quick comment from Dr. Deopujari, and then we can go to the next talk.
I think given the circumstances in a patient who was otherwise moribund, had developed other dysfunction, doing a minimally invasive approach, which was stereotactic aspiration of the cyst and insertion of reservoir, was probably a good alternative, and obviously it has worked. Has the hypothalamic dysfunction considerably improved? That was my only query in this patient. You have shown that the patient has had certain difficulties, but what has been is the failure to thrive and the other, performance in terms of hypothalamic obesity and other eating disorders, etc.
So the pre-op, the hormonal assessment was normal. So after the surgery, he did require the replacement, but the dosage remained the same. And main thing was that he is still independent for his activities of daily living, and visual acuity is also intact. The only thing is that he was lost to he could not continue in his school because of the poor scholastic performance.
He had short stature, but I don't think he had obesity. He did not have obesity.
He did not have obesity.
And no somnolence. The sleep pattern was normal.
So I would say that was a very very good decision and very good way of managing the patient.
Thank you, sir. I think we'll go to the talk by Dr. Aliasgar Moiyadi next. Dr. Ali is a professor of neurosurgery from TATA Memorial Center from Mumbai. He will talk to us on perioperative management of craniopharyngioma. Dr. Ali, please.
Yeah, thank you. Can you hear me now? Is the voice coming?
Yeah, please
okay?
go ahead. Please go ahead. It's good.
Yeah, okay. Thank you. So, thank you, everyone. And I know we are probably a little behind time, so I'll try and kind of be brief. I think excellent case presentations, and I think an excellent format for discussion, learning, and teaching. And I'm going to kind of summarize what has already nicely been already described in the last two cases. So, essentially, craniopharyngioma surgery is something which is there are a lot of discussions on surgical approaches, surgical techniques, but I think an important and an equally important component of good outcomes is the perioperative management. And I think craniopharyngioma surgery epitomizes the need for excellent perioperative management. So I'll skip this. This has already been nicely described. I think we all agree that the goal of treatment is to strike the ideal balance between a good resection, which dictates oncological outcomes, and at the same time preserve and improve, if possible, functional outcomes, which are multifactorial. And we must always keep in mind in this decision making that surgery is one of the options, and there are other options also available, like we've already briefly spoken about, including adjuvant treatment, radiotherapy. And this becomes an important consideration in the decision making. So what I'm going to focus on is the perioperative care, and I'm going to deal with it in these 3 or 4 main headings. So perioperative management and optimization starts in the preoperative stage. We've already had an excellent talk on radiology, and I'd just like to highlight that a few things that are important to reinforce are some red flags which will determine not just the outcomes and prognosis, but also your management strategy, including surgery. And this include hypothalamic involvement, infiltration, as can be evident on radiology, the presence of hydrocephalus. We've had a good, both the cases actually had hydrocephalus, and we discussed pros and cons. And then certain factors which might dictate certain challenges during surgery, like vascular conflict, and which can have sometimes fatal consequences. So this is important because it kind of tunes your surgical strategy. Also, we've discussed, and this is very important, to have an optimum endocrine evaluation in the preoperative setting. If it's not an emergency, it should always be evaluated. There is a high prevalence of preoperative endocrine dysfunction, and figures vary. Some of the series even report as high as 70 to 80%, and this is because of a combination of hypothalamic dysfunction as well as stalk involvement. And important to note that preoperative endocrine dysfunction, especially panhypopituitarism, predicts a poor postoperative endocrine function. And there is a school of thought which suggests that if this is present, then maybe stalk sacrifice intraoperatively can be considered for oncological outcomes, because endocrine outcomes are likely to be the same because there is already panhypopituitarism present. I would emphasize that multidisciplinary care is important, and it's always better to involve an endocrinologist and a pediatric endocrinologist right at the onset. The preoperative workup would include hormones, both anterior pituitary hormone evaluation, and we'll just talk about it quickly, and posterior pituitary function also. So like it was adequately shown in both the cases, I think all the hypothalamic pituitary axis need to be evaluated. Cortisol and thyroid are very critical, but equally important are the gonadotrophin axis as well as the growth hormone, which can have significant consequences in the long term, especially in children who are in the growing phase of their life. However, of more urgent importance are the cortisol and thyroid, and this can be evaluated by free cortisol and ACTH stimulation test if required. It is important then to institute hormone replacement, especially for cortisol and thyroid. The doses are adjusted as per the weight and body surface area for children. Point of note here is that it's critical to start with steroid replacement in case patient has even thyroid dysfunction. That can be started usually a week or 10 days, and approximately 10 days to 14 days is ideal after cortisol steroids have been adequately replaced. But sometimes you don't have enough time to do that, and it can be considered in the postoperative period also. In patients who have steroid deficiency or hypocortisolemic, you have to have stress doses of steroids started, and in the context of surgery, and not just surgery for craniopharyngioma, but remember, in any other surgical procedure that this patient may require, it is important to have stress doses of hydrocort, which is given at the time of induction and continued over 24 to 48 hours and then tapered. If the HPA axis has not been evaluated prior to that, you could do that after the stress dose period is over. And remember, in the long term, if the patient is panhypopituitary, basically has central hypocortisolemia, then you may have to add a mineralocorticoid at some point of time in order to achieve sodium homeostasis. We all know, and I think is one of the most important problems that we encounter in craniopharyngioma treatment is diabetes insipidus. Though it is not a very common presenting feature, it may be present silently and definitely is a big consideration in the perioperative period. We evaluate that by checking serum sodium, electrolytes, specific gravity of the urine, as well as urine and plasma osmolarity. Urine specific gravity is actually a very easy and a very inexpensive bedside test and can be done. If this is present, then preoperatively, you need to correct it by starting low dose synthetic analogs of AVP with minerin or desmopressin, 0.1 milligram HS approximately, or adjusted for weight in children. Remember, if this is done and the patient comes with already having started DDAVP and you're planning surgery, then it's better to stop or to omit the night dose. Usually these are given HS, so that on the prior to the day of surgery, because there can be a lot of fluid losses and fluid replacements that happen intraoperatively, and there could be fluid overload if the patient is already on the desmopressin. Visual evaluation is an important component of preoperative management. Symptoms may be present, but in the absence of symptoms also there might be visual deficits, and a detailed evaluation is crucial for all these patients. In patients with severe visual deficits, it's important to prognosticate, and it can also help determine surgical strategy in conjunction with the radiology and the location of the chiasm and the optic nerves. Anti-epileptics generally are not given prophylactically, though some people would prefer to, but many patients come with anti-epileptics already having been started, and they can be continued. If there are seizures, obviously you give them. There is a thought that carbamazepine can be the anti-epileptic drug of choice in view of its SIADH-like effect, and that can counter the DI that may set in the postoperative period. We don't use that regularly, and our anti-epileptic of choice is still levetiracetam. Having optimized the patient preoperatively, it's important to continue that intraoperatively. And though a lot of intraoperative decision-making revolves around surgery, surgical strategy, I think fluid electrolyte management, which is usually done by the anesthesiologist, I think is also very crucial. quickly just going through them. Surgical approach we've already discussed, and I don't think it's in the scope of this talk. How do you select an open transcranial approach versus an endoscopic endonasal approach? The corridor that you would need to, and in case of an endoscopic endonasal approach, the repair becomes crucial. Remember, if you're doing that, there will be a nasal pack, and you would not be able to use nasal puffs of desmopressin, but there are alternatives that can be done. In terms of surgical philosophy, radical versus conservative, again, we've discussed that in this webinar. The rationale for stock preservation, I think it's important to preserve it as far as possible, but may not be possible in many cases. Remember that endocrine outcomes are better if stock is preserved, but not necessarily always, which means that to get a good endocrine outcome, you should try and preserve a stock. It's necessary, but not sufficient all the time, because there can be other mechanisms by which there can be endocrine dysfunction, which includes hypothalamic injury, ischemic insult. And then always remember that there is adjuvant therapy and other alternatives which can back up a subtotal resection. The microsurgical technique, I think I don't need to go into too many details, but it goes without saying that meticulous microsurgical technique protecting important critical neurovascular structures is important. A point to note here is that try and contain, it's not possible to completely avoid, but try and contain the spillage of the fluid, which can be very irritant and can lead to aseptic meningitis. Prolonged steroid use may be required in such situations. I think the main crux of good intraoperative management is the fluid electrolyte management, and I'll talk about it a little more. If patients have not presented with DI, DI can set in intraoperatively as early as a few hours. And it's important to monitor urine output electrolytes periodically intraoperatively. Most of the management revolves around appropriate fluid replacement and compensation for the urine output, and rarely would you require ADH replacement intraoperatively. The maintenance fluids choice varies, but generally there is consensus to use half normal the half-strength DNS and replace the insensible losses. And if there is increased urine output because of DI, that can be replaced with combination of half normal and normal saline, and in extreme cases with free water with dextrose 5%. As I said, intraoperatively, rarely would you have a situation where you might have to give vasopressin. That usually happens in the postoperative period, where DI is the main concern. DI is defined as polyuria. The normal range for urine output is 1 to 4 ml per kg per hour, and if this is exceeded for 2 consecutive hours and is associated with hyperosmolar hypernatremia and hypoosmolar urine, this is considered as DI. It's because of free water loss, because of absence of ADH. But in the immediate postoperative period, beware. This could be a rebound polyuria because of a lot of fluids which are given intraoperatively. To differentiate that, urine sodium and osmolarity will help because it would be higher in this case. And the treatment for this kind of polyuria is usually to reduce or restrict the fluids rather than give fluids as you would in DI. So be careful in the first 24 to 48 hours. General principles of treatment of DI is to attempt replacement with hypotonic fluids and match the urine output over and above the basal maintenance fluid rate that is required. The patients are alert, awake, and have an intact thirst mechanism. Oral replacement with water is what is recommended. Don't chase the urine output if it fluctuates for a brief period. But in patients who have very significant polyuria or are obtunded, you would need some kind of IV fluid replacement. And when that is insufficient, you need to add vasopressin. Again, remember that DI in the postoperative period can be triphasic, and this is very well described, and I think all of us know that there is an initial phase of DI because of stock transaction, followed by release of stored ADH because of degeneration of the neurons, which causes a phase of SIADH, which is usually transient. And then this finally merges into a permanent phase of DI, which is a little delayed. This is classically described, but it may not always be there, and there can be various combinations which you might encounter. So always be aware. As I said, the fluid recommended is usually hypotonic fluids, and it's preferable to use half normal rather than D5, because D5 can cause a lot of fluid overload and hyperglycemia, which can itself cause rebound polyuria, which is actually counterproductive. Monitor intake output hourly, and that has to be strict. Sodium in the first 48 hours needs to be done every 6 to 8 hours, and if necessary, paired assessments of serum and urine, sodium and osmolarity. And as I already said, specific gravity urinary specific gravity bedside can be a useful, quick, and inexpensive way of assessing whether the urine is becoming hypoosmolar. If fluid replacement is not enough, you need to give vasopressin. Again, in the immediate postoperative period, it's better to use vasopressin, pitracin. We prefer giving it IV or subcut. Shorter acting than desmopressin. And because in the immediate postoperative period, there can be fluctuations. There could be a phase of SIADH, which may come in as early as within 24 hours or a little later. And therefore, a shorter acting vasopressin is preferable so that you do not have problems of severe SIADH. Once that acute phase is over and past, you could then switch over to the longer acting desmopressin, which is either tablets or spray, but tablets is preferred, and that can be given both in pediatrics and adult patients. This is what is preferred, desmopressin, and it is preferred because it has negligible vasomotor effects and has predominant, almost exclusive antidiuretic effect. Because of a long plasma half-life, it's better to avoid it in the immediate postoperative period. Besides fluid electrolyte management, I think a routine postoperative MRI is important within 48 hours. If not, then you could at least get a CT scan, look for residue, look for collection, look for ischemia, hydrocephalus, all are important. And also assess vision in the immediate postoperative period. If there is a nasal pack, with continue antibiotics, anti-epileptic prophylaxis, as I already mentioned initially, and watch for delayed hydrocephalus and aseptic meningitis, which can occur in quite a few patients. Of course, if it's an endonasal surgery, you have to decide when to remove your nasal pack and appropriately manage that. The other important aspect of postoperative management is the endocrine evaluation and the replacement. As I already said, there is a high incidence preoperatively, and that worsens, usually worsens in the postoperative period, even when your stock is intact and hypothalamus is not injured, obviously injured. Growth hormone and other hormone axis are important, and they need to be, but the immediate postoperative period crucial is to have cortisol and thyroid optimized. You can replace it if it has already been evaluated preoperatively. Continue the replacement for steroids. Once the 48 hours of stress doses are over, you can switch over to the physiological replacement dose, and then continue that along with thyroid if required. Growth hormone replacement can be started later, usually after tumor oncological control is optimized, and depending on the age of the patient, because growth hormone replacement is costly and not all patients may be able to afford it for an indefinite period of time. You have to time it with the patient's age and the pubertal spurt. This is important in the long term. So once the patient has undergone surgical rehabilitation, if there is ophthalmological deficits, then you have to get them to low vision rehabilitation. We've already discussed neurocognitive rehab as well as optimizing scholastic and social performance. We've talked about endocrine growth hormone replacement, and that's best done in conjunction with an endocrinologist. And of course, the discussion about adjuvant therapy, depending on the surgical residue, age of the patient, and of course, the type of the tumor. So I would kind of summarize this by saying that, there is more to craniopharyngiomas than just surgery. I think we all agree. Post-operative, perioperative management, especially fluid electrolyte optimization is crucial for outcomes. A good surgery may not necessarily lead to a good outcome unless everything else perioperatively also is optimum. And I would say it's a teamwork along with intensivists and endocrinologists. Thank you.
Yeah. Thank you, Dr. Ali. This talk is specifically kept because many times all of us have noticed that we would do a good surgery and come out only to find that it's very difficult to manage the patient post-op and develop complications which are sometimes beyond our control, and then either the patient does very bad or sometimes we may end up even losing the patient. So it's very important to not just know how to operate but also to know how to manage the patient intra as well as post operatively to get a good outcome. Again, there's one question from the chat box. I would also, I mean, like I said in the beginning, this whole idea of format is to encourage audience and residents and young neurosurgeons to ask more questions so that it will become more and more interactive. There's one question from chat box. What is the incidence of post-operative vasospasm and management? And is there a way to prevent? And is it different between adult and pediatric? Dr. Ali, would you like to comment on that? Post-operative vasospasm in craniopharyngioma.
So I must say I don't have a figure in mind in terms of how often it can happen, but it can happen, and the manifestations can be, of course, with neurological deficits and obtundation, but it also can be manifested by endocrine dysfunction and pituitary dysfunction. I would say management basically starts intraoperatively, basic techniques of avoiding too much handling of all the vessels as well as the named vessels as well as perforators. And I think that is very, very important. Vasospasm can also lead to optic dysfunction in the postoperative period, and therefore, in these tumors, trying to be radical dissecting it from both the optic apparatus as well as pituitary stalk and surrounding perforators has to be done very, very carefully. And it's better to err on the side of removing less than damaging any of these. If it does happen, I'm not sure whether there is anything specifically beyond treating it symptomatically that can be done. But maybe you or any of the other panelists have some.
Yeah. So I'll just add on to that because I presented a vasospasm post-op case in the last INDSPN conference. So that time I did some literature review. The incidence reported in literature is 3.5% of patients who undergo surgery for craniopharyngioma. And there are two papers from PGI Chandigarh on vasospasm after craniopharyngioma surgery and delayed cerebral vasospasm. So yes, if we suspect vasospasm, we manage like what we do for aneurysm surgery. I start one of the two, I think a few cases which we had to manage. I started on nimodipine, and in one patient we did an angiogram and gave intra-arterial nimodipine also. So if we suspect vasospasm, then I think we should manage as how you would manage a vasospasm in subarachnoid hemorrhage, and it would help. One last question from my side, if there are no more questions. I think there's always a confusion doubt. Which steroid is recommended for replacement in these children? Because earlier we used to give prednisolone, there is hydrocortisone, there is dexamethasone. This is for clarity among the steroids, which is relevant or recommended for patients with craniopharyngioma. I'll take a comment from Dr. Ali and Dr. Deopujari on this. And with that,
I think as a replacement for dysfunction, I think it is a choice between hydrocortisone and prednisolone. Dexamethasone is not really the replacement, the steroid of choice for dexamethasone has essentially almost 100% of cortisol activity and no mineralocorticoid activity. The
Yes.
other two have a little bit of it, and that's what is preferred. And their doses are more or less similar, maybe 20% lesser. So essentially, what we would give is either prednisolone or hydrocortisone.
Yes. Thank you. I think that's what we're doing. We used to give prednisolone now with more interactive management with the endocrinologists. They advised us to give hydrocortisone. So we give hydrocortisone. Are there any questions? If there are no questions, are there any questions from audience? Anybody wants to ask? We are just. I would request Dr. Deepak Gupta, President INDSPN, to give closing remarks.
No, I'm sorry. I joined very late because I was scrubbed up in the surgery. I joined when the last talk with the resident going on. So this is the first talk I think of this season, and I hope many more to come. Congratulations to Ari and Ranjith for organizing this, and thank you everybody for joining it. And the next month, any topic we have decided?
We have pineal region tumors.
Pineal region tumors.
Perfect. And the dates have been announced?
Yes, yes. Yeah, I would like to say we would like to keep it fixed so that there is no it becomes uniform. Every third Thursday of the month, 7 o'clock, we will have the session so that it becomes a routine and we don't need to change over time. And we'll fix it for. We would like to have it on Thursday, every third Thursday of a month. We will have INDSPN virtual classroom. Like I said in the beginning, we will have two short talks, but a predominant time of almost an 1 hour we will dedicate to discuss cases so that the residents can present and residents as well as young neurosurgeons can discuss and we can understand the nuances of real world neurosurgery management so that we look at cases. And my sincere request is I request residents and neurosurgeons to spread the word so that more and more people can log in and benefit and ask questions, ask your queries, be open. There is nothing to be reluctant about, so that it becomes more interactive. Thank you very much. For today, I thank Dr. Subhash and Dr. Ali for giving such excellent talks, down to earth, what is required for day-to-day management and surgery. And thank Dr. Dilip Panikar and Dr. Deopujari for joining us and giving their wisdom and pearls for understanding. And I thank the Dr. Ranjith, regarding the case presentation, I would request you to thank the people.
Yeah, I would like to thank Dr. Shweta, who for guiding Dr. Prakash, who presented a case with radical excision, and I would like to thank Mehul for having presented a long-term outcome case with a different strategy of management, and Dr. Anand for helping him with that. I think with that we will close this webinar.
Thank you. Thank you, sir.
Thank everyone for.
Thank you very much. Have a good evening.
Bye.
Good night. Thank you.
Good night.